Treatment center staffing requirements have no single national grid. Generic staffing templates tend to fail. Requirements depend on the level of care, your state's licensing framework, and the accreditation standards you've agreed to meet. Staffing is a licensure and operations question, not just an HR question. State regulators define the baseline. Accreditors like the Joint Commission and CARF add quality and process expectations. Your actual census and acuity decide what is operationally safe. In this video, how staffing flows from level of care, what state rules expect, the 4 categories to define, and the workflow that backs it all up. Staffing should be built from the program model outward. The level of care, the services delivered, the state's licensing framework, and the payer standards you've signed up for all shape the requirement. A plan that works for weekly outpatient therapy will not satisfy a daily PHP or a medically supported detox environment. Here is the cost of getting staffing wrong. Many organizations underestimate the staffing needed to keep assessments, treatment plans, concurrent reviews, and payer communication current. Understaffing there usually becomes a denial problem later. And regulators want evidence that staffing matches services, credentials are valid, supervision is documented, and patient safety is covered. A staffing plan is only as strong as the workflow behind it, and this is where systems matter. Operators should be able to show current credentials, training completion, supervision cadence, schedule coverage, and documentation timeliness. Behave Health's platform is designed to keep scheduling, documentation, and accountability visible across the whole team as your census grows. Start with level of care. 3 program models, 3 different staffing pictures. Let's walk through them. First, residential and detox programs. Residential and detox programs need stronger coverage expectations. Second, partial hospitalization programs. PHP needs daily structured clinical availability, plus tight attendance and documentation control. Third, IOP and outpatient programs. These allow more scheduling flexibility, but they still require documented supervision, credential coverage, and treatment planning capacity. State agencies usually define the minimum, and the details differ state to state. California's DHCS ties licensure to covered services and level of care expectations. Florida's DCF manages provider licensing for substance use services. Minnesota points operators to the governing statutes. Nebraska describes application, inspection, and regulatory review. Titles and ratios differ, but every regulator wants staffing that matches services, valid credentials, and documented supervision. Next, the 4 staffing categories most operators need to define. Here they are. 1. Clinical leadership. Who owns clinical quality, supervision, escalation, and scope of practice control? That may be a clinical director, medical director, or nursing lead, depending on the program. 2. Direct care coverage. Who is physically available to patients, during which hours, and with what escalation path? Residential and PHP programs need especially clear answers here. 3. Documentation and utilization support. The staff who keep assessments, treatment plans, concurrent reviews, and payer communication current. It's the category many organizations underestimate. 4. Admissions and authorization. If the center depends on commercial or Medicaid reimbursement, insurance verification, authorizations, and admissions coordination are part of the staffing model, not separate from it. Stop building staffing plans on generic templates. See scheduling, documentation, and accountability designed to stay visible across your team. Book a 20-minute demo at behavehealth.com. Get help mapping compliance to your actual operating model. Book a demo at behavehealth.com.